Hey everyone, good evening. Thank you for coming today to Fawwaz's talk on our most favorite subject, prior auths. So I will hand this over to Fawwaz to introduce himself and then teach us about this process.
Thank you, Paulius. Hey, everyone. Fawwaz here. Work for Elevance Health as a strategy director on the clinical platforms team. And when I say clinical platforms, essentially we're talking care management, utilization management, and provider services. Today's talk is about utilization management and the platforms and the services that work together to bring to life prior auth when providers submit it. So this is essentially the back end view of what happens after providers have gone through the painful process of submitting a prior auth. Okay, so we'll dive right into it, right? Essentially, so this diagram goes from left to right, and the way we think about utilization management, which is prior auth is a part of utilization management, and utilization management is a couple of processes within it, right? So grievance and appeal is also utilization management, right? A prior auth, if it goes straight through, is one part of it. A concurrent review usually happens when an individual or a member is inpatient at the facility and they need an immediate review if they want to stay a day or two more. So a prior auth is submitted from the facility, and then we say, okay, they can stay a day or two more or not. That's concurrent review, also part of the prior auth flow. And then finally, if a prior auth is rejected, then provider can file an appeal, and then that appeal is looked at again. And that is also a separate, disparate part of the utilization management process. And the utilization management process, essentially, you have to think about it as a hammer, right? It's a very broad-based hammer that we used to contain costs, right? It's not a precision tool. It's not something that payers have typically been sophisticated about. And I'll tell you how we calculate on what. So if focusing on outpatient, on certain procedures, it's an interesting calculation that we do on determining whether a particular procedure code would require prior auth or not. So it's again, like I said, it's a hammer, it's a front end tool that we used mostly for sentinel effect against providers where we think there is low value and high cost, usually, right? There are other elements to it as well, and we'll dive right into it. So when a provider, right? So before a provider submits a prior auth, the question that first comes to mind is whether a prior auth is required or not. And in making that determination, 2 or 3 things need to be kept in mind. The first is benefit structure. Now, benefit structure is not something that comes almost entirely from the payer space. Benefit structure can come from employers, and Paulius likes to correct me in saying employers are also payers. In my mind, they're separate because they're clients of ours. But a lot of times, benefit structures come from either the state or the employer, or if they're fully insured, from the payer as well. And what's interesting, and this is fascinating, it's a chicken and egg problem sometimes. Do I submit a prior auth because the member does not have the benefit? Or once I submit the prior auth, will the team on the payer side check for benefits and approve? And sometimes you don't know the answer. And you might find it odd that these large organizations don't know the answer. The reason why we don't know the answer is because when we're selling contracts to employers, to individuals, mostly to employers and states for RFPs. We will bend over backwards. Our salespeople will bend over backwards to include anything that the client wants in that contract. Give me one second. All right. So our folks will bend over backwards to write anything in that contract, and once everything in that contract is written, utilization management is a downstream process, and then we'll try to figure out what was sold, right? And it's so interesting, it's so backwards. It's never communicated downstream what we are selling. And it's not, plans like T-Mobile or AT&T or Verizon that you go and buy and saying, this is Magenta or this is Magenta Plus, or, it's not like that. These contracts are incredibly convoluted. They have these things called carve-outs, essentially saying, my population, if they want, let's say, they want chiropractic services, it's a carve out. Tell them I'm not covering it. If anyone has chronic kidney disease, tell them I'm not covering it. And sometimes employers are doing this to their employees, but the insurance company is getting a bad name. So that's step number one. For prior auths, whenever you're submitting it, think benefits first, right? Does this member have this benefit? Yes, no. Okay, maybe I have to submit one. And oftentimes, you submitted either via 3 channels, digital, phone, or fax. And the digital channel, previously it was EDI, which is electronic data. I'll come back to you on the I, but right these days it's a portal, right? Most payers outside of United use a service called Availity. So it's a separate company. It's almost like Zelle. It was bought up by different payers so that providers have less abrasion. So most providers would know what Availity is, at least inpatient providers and outpatient people running their practices. I know a lot of folks on this call are the DPC crowd, so maybe you guys are not too familiar with Availity, but Availity is, its corporate structure is that Elevance owns a small part of it, and Humana owns a small part of it, and Aetna owns a small part of it. United is the only outlier out of the large payers. So you go into a portal, or you pick up the phone, or you fax some documents over, right? So we create a case. So once the case is created, it gets sent over, and then we create the same case that the provider has sent over. Our systems consume it, and we create a case within our system, right? Our system is called ACMS, so that's why I put the name there. All of these, and what I did was, a lot of these have internal names, and there are about 7 systems here we can talk about, and each one of them has their names and acronyms. People work at Elevance for 5 years and they won't know what one acronym is from the other, right? So I'll give you an example. ACMS is Anthem Care Management System. And there's an interesting thing called ACMP, which is Anthem Care Management Platform. And then there's another funny thing called Anthem Care Management. I forgot what the R stand for, but there's a thing called ACMR. So there's ACMR, ACMS, and ACMP, and all of those mean similar things but a little different. ACMR is the database, ACMP is the platform, and ACMS is the suite of products within. So it's quite crazy. But we create a case on the platform, right? And this platform is where the nurses and medical directors will come in, look at the case, and make a determination. We don't get all the information from Availity. We get some information from Availity, but not all information from Availity. Because the member information and whether the member has benefits for a particular procedure or not actually lie within our source systems. So provider submits that, let's say Paulius needs knee surgery. He will enter, Paulius's, let's say, member ID, group number, subgroup number, and then enter which plan he has, right? And then the provider will enter his details. That information comes over. We then check Police's name across our systems. There's a API call to benefits, and it comes back and says Polius has that benefit, doesn't have that benefit, and about 50% of the time we say we don't know. So this service that we say we don't know is before LLMs, all of this was in unstructured data because that's how contracts are written. And we create engineers used to go into this unstructured data, write rules so that this API call would become easier. And what happened over the years was, as you renew contracts and, let's say you submit an RFP for the state of Virginia, let's just talk about a Medicaid product, right? And every 3 years, I think, is the renewal, or every 2 years. So every 2 or 3 years, these contracts are getting updated, and the engineers are going back in and writing rules. So it was a crazy process with lots of costs, and it's still going on. So the benefits is one problem that we're still trying to solve. Major problem. The other thing that we make an API call to is provider. Now, we expect Availity or the intake system to tell us, who the provider is, but what kind of a relationship do we have with the provider? What kind of a contract do we have with the provider? Certain providers will practice in multiple locations. Sometimes they're in network and sometimes they're out of network. So for example, if Police practices at Houston Methodist, he becomes in network. But if he practices at MD Anderson here in Houston, he becomes out of network. So what kind of a relationship? And let's say, he runs a surgical center, then we have a separate relationship with the surgical center as well. And so we also make an API call to our provider systems, which are very expensive to build and then maintain. So that's another system that we make an API call to. So make a few API calls and build this case before anyone touches this. Oftentimes what happens is that some of these validations that I'm talking about, such as benefits and provider, fail. And when these validations fail, you have something called intake staff. And intake staff is, individuals who have been trained on the system, who've been trained on how to fetch information, but do not have clinical acumen on making decisions. They do, however, do something called administrative denials and administrative approvals, which is we will have certain cases which don't require clinical judgment, which we will say that intake staff can approve or reject. And as we make that's one part of saving. So, my job essentially is to look at this process and say, where can I save the most amount of dollars? And you see the dotted blue line, that's where the majority of the dollars are. That's where the nurses and the physicians sit. And my job is to make sure, how do I automate this away to the extent where I save a lot of money? Now, since I've touched about savings, let's talk about something that I touched earlier, right? How do we determine whether an auth is required or not? And this is the best part. So let's take a procedure code, right? Let's say knee surgery, whatever the procedure code for that is. And we say that every year, let's say there's 1,000, knee surgeries that happen. And every knee surgery, on average, right? So again, every knee surgery would be different. We would pay out different. It would cost us different depending on whether the facility is in network, out of network, yada, yada. But let's say on average, every knee surgery costs us $10,000, right? Now, 1,000 cases came in and we rejected, let's say, 30 of them, right? So we rejected 30 of them. So we're left with 970. So we saved about $300,000, right? So each procedure was $10,000, right? We denied 30. Had we not a prior auth, if the prior auth was not there for knee surgery, every case would have been approved, or we would have paid out claims for every case, which essentially means by denying 30, you save $300,000 for the insurer. Now, the determination whether an auth should sit there or not year on year is we take how much did it cost for us to make a decision on these cases. So we take the salaries of the nurses and the physicians making a decision, we average them out, and then we multiply that or put that on the other side of the equation in seeing what is more costly. So if I save $300,000, but the cost to make those decisions with these expensive nurses and physicians was $200,000, then I will make sure that the prior auth remains there. I'll pause there. Any questions? I know that was a little upside down.
So this is really fascinating to kind of peek under the hood. What if you are in new territory where you don't have the benchmark cost of basically labor to, account for whether
Yeah,
it's
that's a great question, right? And when you say new territory, as in you're getting into a new market, is what I'm assuming. Is that right?
or even just, when you are, I guess like GLP-1s would be an
Oh, I
example.
see. Yeah,
Where
yeah.
you
Like
have
a brand new procedure or a drug. Yeah, yeah, yeah. No, that's a great question. Yeah, the first instinct is to deny. You know, you see, it's not a question of whether we'll sit around and see, how it impacts claims. We're just going to deny, and then we're going to say, all right, the endocrine society, and then the cardiology society, and then GLP-1, right? Who else would be involved in that? But let's say the Internal Medicine Society, whatever, right? All of them have agreement. We have, 5 meta-analysis, right? 200 RTCs. Then we'll be like, okay, maybe we'll approve half of them. That's what it's. It's not. It's never. Insurance is never is we offer a financial product. You have to understand the game we're playing. We're not in the business of cutting edge medicine. That's not our business. Our business is here's a financial product, and this financial product helps pay for people's healthcare. So I want to make sure that as many people have healthcare or are, we can pay for their healthcare as possible. And so to maintain the viability of this ship, I need to cut costs and make sure that, my adverse selection or my, high risk members or high utilizers don't sink it or don't, make the water on board. Michael, I see you have a question.
Yeah, I was looking to see the visibility of the process. And just can you speak on why is it hidden in so many ways? I mean, obvious reasons
Yeah.
maybe prevent gaming.
I didn't know it was hidden. Maybe I'll get into trouble
Hidden.
for this talk.
It always
It's
seems
not,
to
yeah,
be
that's a
a
great question.
mystery.
It's not really hidden,
Maybe
yeah, I mean, it is hidden, but it's not really hidden. It's something that I think typically providers and clinicians have not taken an interest in understanding how insurance works. I think prior auths are sensationalized by media and physicians. There are memes about it, there are TikToks about it, New York Times does a video on it, and without really understanding what's going on. We communicate a lot with large systems. Like Cleveland Clinic is one of our biggest partners. We're always communicating with Cleveland Clinic. We're always rolling out new technology, making sure that their physicians find it easier to submit prior auths, again, we can't always talk to them about procedure line, differences or procedure line items because remember, it goes back to benefits. We don't know who Cleveland Clinic is seeing or not seeing, right? And unless, we are only concerned about Anthem members, right? And we know that Cleveland Clinic sees a lot of Anthem members, but procedure line level, you know, prior auths are a physician specific problem, right? Even we don't have visibility into, let's say, what United has on their PA list, or Aetna has on their PA list. But it's not really hidden. I think it's just sensationalized to the level where
Oh, that's a good point. It's like the interest. It's well, you
right.
get the information as long as someone's interested in it. I think that's
Yeah.
I think that's a good
Most
way.
of it is available. I mean, Availity is a good product. Availity we'll talk about it. If you go to their website, you watch their YouTube videos, that's what they do. They talk about prior auths from sun up and sun to sundown. I know Sarah has a question. I'm wondering how much money per member per month or per year this process costs into the insurance company versus how much money is saved in utilization. And then I'm wondering what percent of the savings is accounted for by prior authorization requests from primary care specifically. That's a great question. So primary care, is not on, let's say, when it comes to prior auths, the only thing for primary care physicians that might be a problem is RX. And those lists are published on the website. That process is fairly straightforward now. It's been fairly simplified. But primary care physicians usually are our friend, right? Where we know they're not going to be doing expensive procedures. They're not going to decide to remove someone's kidney with radioablation or something crazy. But how much it costs? Great question. It all goes down to the procedure code level detail, right? So overall, I can say that we save money with this process than not having it in. And those lists of which markets want prior auths and which markets don't is always revised. So you will literally see people in Georgia using a particular service more. And then someone in the market of Georgia will say, like a market president will say, I want that service back on the prior auth list. And this is again for commercial, fully insured clients, right? Usually. For Medicaid and Medicare, we don't really have that say. Usually our friend, yeah. Paul, yes. Yeah, they're usually our friends, right? Okay, so back to the diagram. The dotted blue lines, that's where most of the meat happens, right? You have an initial clinical review that's done by the nurse, right? If the nurse is unable to make a decision, or she thinks that my clinical acumen is not sophisticated enough to make a decision here, what is she using to make a decision? These are published guidelines called MPCGs, or medical policies and clinical guidelines. You only use for two kinds of procedure. The first is high cost, low value procedures, which we think will not help the patient. MPCGs are printed by two major companies, Interqual and Magellan. Magellan and Interqual, right? So MCG and Interqual, most insurance carriers will use those two to make a determination. And if you go online and look at these medical policies, they're very sophisticated documents. They will have citations of RCTs and meta-analysis and everything, right? So the nurse will look at those, and the nurse will then look at the case and says, does it make sense or not? And if the nurse is unable to, then it goes to the MD. The nurse is cheap compared to the MD. So the more time the MD spends on a particular case is more dollars that are now being charged for that particular case, right? And I know the finance is a little funky. I know these guys are salaried, but that's how we make, because the way I look at it is this is a factory floor. And on the factory floor, I want as little or as low of high expensive workers as possible. So that's my view, right? So if cases are going to the MD, more often than not, that's a problem. And I want the MD to not check benefits. I want the MD to not do any validations that the intake staff is doing. That's why we have this process. Intake staff, you do all the grunt work. Nurse, practice at the top of your license, and physician, don't you dare touch any other system. Look at the case, make a decision. That's it. So as little time as possible. Let's say the case is denied and someone, provider says, and JD posted this really fantastic graphic, right? But, providers are pesky. I call them pesky providers, right? Someone says, "Oh, I don't deny, I don't accept this denial. I need a P2P." And somehow they get through to an insurance, medical director, which is feet on its own. But let's say they get to a P2P. Now that's costing me more and more money, right? And then it's denied, then they say, I want an appeal. So they file an appeal, and then there's another review. So in that little box is where the dollars are. That's what happens on the platform. Now, everything to the right of that little box is once a decision has been made, whether approved or denied, we then send out a letter. We then tell the provider and the member, and let's say it's approved, we then send it to claims as well. So we send this clinical information that was sent in the prior auth to claims, because this is the interesting bit. Sometimes the claims team will say, I need more clinical information. Even though the prior auth team got every bit of clinical information possible, sometimes the claims team also say, I need more information. So we send out, documents to the claims team. Claims teams looks at them, and often, more often than not, they say, yeah, I need more documentation before I pay out, $100,000 to this particular surgeon. So, and then, the last little box there is reporting. So we report out to the state agencies, we report out to CMS, on how the state of the prior auth. And then there are some final rules coming up around prior auth optimization from CMS that we'll have to implement as well. Not too difficult to implement for us. We're already kind of there. So one last little box that I want to show you, which is a little box, but is also very sophisticated. A lot of times employers and states will have already picked a utilization management vendor and say, my will be done by Accolade, or my will be done by, someone else, right? Let's say TriZetto. You see that delegation check? When the provider enters the portal, sometimes we do a delegation check whether this particular contract has a delegated vendor or not. This process of onboarding delegates with our source systems and giving that information is worth millions of dollars. So it costs us and it costs the entity that has done the delegation millions of dollars to essentially integrate with our systems. And so it's one of our goals as a clinical strategy team is to make our platform so sophisticated and so user-friendly that it is the choice of the platform rather than this delegation, right? So this delegation check, this little box that you see at the bottom, costs us a lot of money from a tech perspective. But I'll pause there. I know I said a lot. It was a fire hose. I can go on for another 20, 30, 40 minutes, but I think that's enough prior auth. This is the most simplest overview that I can give you. There are other processes that happen in the background. There are other complexities, other technical complexities, and then process complexities. But I'll pause there and then open the floor to any questions.
So I'll return to Sarah's question because you answered the second part, but she was wondering if like money wise, the PMPM for utilization, do you know if those numbers exist? Or
those numbers do exist. I can't go too much into it. Again, they're procedure level data. We do save money. I mean, prior auths help us save money, and that's why they exist.
Yeah. And then Do you can you talk more about the gold card process and like what
Yeah, yeah, great
uh,
question.
not everyone might know what it is.
Right, right. So gold carding essentially is where providers who are consistent in their behaviors of doing sound clinical procedures uh, and give us sophisticated information uh, and have passed all audits that we've thrown at them um, are usually gold carded. Now, that's one gold carding. So that's our own internal program. There's another thing called gold carding that states are now enforcing, which is a problem. I say it's a problem because I think like a bear, right? Because so states will say, Polyus once did carpal tunnel surgery and you approved it. So anytime Polyus now says, I want to do carpal tunnel, you will have to approve it. And that's what the state mandate is. That's also called gold carding. And it's usually based, both principles are the same, usually based on historical data on how provider behavior is. And then you essentially give them a pass for prior auth. So anytime Polyus wants to do a carpal tunnel, his information will flow through the system. No one will make a decision on it, and it'll go straight to claims. That's what gold carding is. And more states are now mandating it. So there are lobbying efforts that are in place to counter that because fraud, waste, and abuse is it's a real thing. But yeah, so that's what gold carding is. The first part is our own program, and then the second gold carding, same name, is what the states are now mandating.
Um, I'll keep asking questions unless y'all have other things on your mind. So feel free to type it in the chat. What I was wondering at the beginning, you mentioned that there are different ways to submit prior auths. You have the
Right.
digital method, you have the fax on the phone.
Mhm.
Do you know that does the mode of submission influence the outcome?
Oh, what a great question. What a great question. Uh, I don't think it influences the outcome. What it influences is the turnaround time. What it influences is the quality of information that is received. What it influences is how many validation checks are failed. And the more you play around with the case, the more you lose information from what was truly submitted, right? So fax and phone, let's say you're a provider police and I'm on the phone with you, right? You're saying something and I'm, saying, all right, I hear you, police, and I'm typing it in, right? But because of multiple people in the chain, the purity of that information is lost. With the digital channel, the information is very sound and it came directly from the provider. Does it impact clinical decisions? We haven't done a study on it. It would be a fascinating study. My first answer would be I don't think so, but it does impact turnaround time and the process flow.
Then I had a slightly different question about like what is there something that clinical teams do that makes payers angry? Is it
Not really.
um,
I think I think it's the other way. I think we do things that make providers angry, but I don't think they can make us angry. And I'll tell you why, because when a nurse wakes up in our system in the morning, she already has a list of cases to work on. Like we've presented a queue to her, here's a list of cases that you're working on. She doesn't have the system level view that, let's say, the tech team or the operations team would have. And we're dealing with 18 million, 16 million authorizations a year. 16 to 18 million authorizations a year. And it's really just routine factory floor work for most of our folks, right? Like I said, we are not in the business of being empathetic about what is happening with each member, with each case. It's a system level view. An auth comes in, let's make a decision on it, let's send it out to letters and notifications. End of story. And you go from there. If a provider has not submitted information, we just say lack of information and we send it right back. It's not, no frustration there. It's a drop down.
And in the box where you say denial notification letters, are those sent out by mail or are they sent out?
Both. Yeah, they're both email and mail. Yeah, that's a great question. There's an initiative that's we used vendors for snail mail, and so we're phasing out those vendors and saving a lot of dollars. It was cents, but again, 16 million times, and even a few cents, and you paying that out year on year. It's a lot of dollars. And sometimes, let's say 5 procedures are being done, that means 5 letters, even though it's the same surgery, you know. Uh, so so it was snail mail usually, but now, we're turning it to digital notifications, and providers don't even open these letters up.
I know Xavier
Alright.
asked the question just now. Xavier, do you want to?
Aside from the whole carve-outs, what would be the downside of flipping the story from ask for approval to approved by default with the right audit and glow? It's a great question, right? There's always an internal discussion about, do we do this and make life easy for providers? And it's an idealistic kind of a discussion, because I think what is lost on in that discussion is the downside is that our offering as a health plan is a financial product offering. It is not, we like to say we're solving, we're your health partners and we care about your health. And, I think anyone who's done an MBA or a mini MBA or, seen business videos online, you will see that incentive alignment is the most important thing in business. And insurance companies don't have an incentive alignment for approving everything the provider sends back to us with audit. Audits usually are very expensive and they're not so sophisticated. It is very difficult to go down to the provider's office and say, are you really doing a surgery, dude? Like, I see you've submitted, 100 claims in the last year. And then you reach out to the members. Members are notoriously bad at picking up phones. You ask members, hey, was this surgery done to you? Most members don't even know what conditions they have. I mean, I'll give you a small example. I was interning at a cardiology office in 2011 in Florida, and I was, let's say, and before the attending walked in, I'm taking down the history, making sure everything's fantastic. So I'm going through the medications, and then I say, yeah, now I see you have heart failure, recently diagnosed heart failure. And the member just jumps out of her seat. She says, heart failure? I don't have heart failure. My heart is just fine. And I'm like, well, it's a technical diagnosis. Heart failure means, your heart is unable to pump blood. So all of a sudden she's mad at me. And the attending walks in and says, I have heart failure. She goes like, you never told me I have heart failure. And he was like, yeah, you have heart failure. And that's what it means. So, when you ask the member, you call in an audit, you call the member and say, was this procedure done on you? And the member's going to be like, what? That was never done to me. So, audits are difficult. And so I think prior auths are the way to go. I should be a lobbyist, that's what I should be.
So what do you think are some of the innovations in prior auths that doesn't just seem
Great
so
question.
barbaric? I mean, you're talking about hammers, right? And like,
Yeah, it is barbaric. I think some of the innovations in the near future are going to be auto approvals. Lots and lots of auto approvals. You take medical policies and clinical guidelines, and then you automate the crap out of them. where nurses and physicians, where I have 5 nurses and 1 physician, I'll bring it down to 1 nurse and half a physician or something. That's where the work is. That's one of the initiatives that we're driving towards right now. With LLMs, this is a technology shift, right? This makes a difference. With LLMs, whatnot, you throw an LLM on unstructured data and it does wonders, and it surfaces up information. So the decision time and turnaround time goes significantly down. And because they go significantly down, now you can pile up the nurse with more and more cases.
This is really interesting. I see, Zach, you're in med school. What do you think about this whole, mess?
Hey, let me think about a question and get back to you in a minute, okay? Because let me sit for a second, okay?
Xavier asked a great question, right? Does Availity have a structural advantage to say Olive and Cohere? So don't know much about Cohere, but Olive, Availity bought Olive, at least the aspect of it. And they renamed their team to Auth AI. So they recently bought Olive, the function of it, and they called it Auth AI. So Availity is a behemoth now. I don't think there's any, let's say, stopping Availity anytime soon.
All right, I have a question. How is something deemed like clinically standard? Like, how can you just what does that algorithm look like where something comes in and it's processed to one of the the intake nurses? Because it seems like, I guess they might have the option of escalating it to one of the doctors on the team. So how does that work?
Right. Yeah, it's clinical judgment mostly. So we trust nurses to make a clinical judgment, not entirely, based on their experience, but also we provide them with medical policies and clinical guidelines that help them guide in their decisioning. And those are published online for most markets, by, again, 2 companies, Interqual and MCG. And so those are kind of the guardrails on how they make decisions. But every nurse's workflow is different. It is, from a tech perspective, I can tell you, it's very difficult to capture that information in saying what was the nurse thinking, because I'm thinking automate, automate, automate. So in order for me to imagine what a nurse was thinking or how did the nurse arrive to that decision, it's quite difficult. I have to go through an enormous amount of data. And the question becomes, is it worth automating this process or not? But those are some of my efforts. Great question.
And so are those 2 companies, I imagine their documents are not publicly available, right? That's just to get access to the different,
Yes, those are proprietary. So those are intellectual properties of MCG. And in fact, if you were to go to, let's say, if you wrote, Anthem MPCG in Chrome right now, it will say there will be a disclaimer, misuse of these policies, is you're liable or something as well. So, like if someone said, I'm going to download all the medical policies and clinical guidelines and, apply an LLM on it or throw them in ChatGPT, so I can tell providers, what to submit, what kind of clinical evidence to submit so that your prior auths get approved. That could be a tool, but the insurance companies might say, hey, you just used our IP in a non-compliant way.
And so many of the startups in the prior auth space, they're basically dissecting this process. And I mean, they're obviously going upstream to just make sure that every box is checked.
Yes.
To increase the approval rate, basically, right? That's their
correct. that's what they're doing. So they will come to us and they will say, give me your medical policies, give me your clinical guidelines, and then our AI will recommend whether to approve or deny your case. That way you can reduce the number of physicians and nurses on your team. Right? That's the $1 million play here. But we're not going to give our MPs, medical policies and clinical guidelines. We're not going to hand them over. If we own them, we can. But if we're borrowing them from Intercall or MCG for certain markets, then that becomes another very sticky and difficult conversation.
Can members, patients request those?
Ooh. They've never requested it, but you can ask for a decision. I know that members can request for a detailed description of what the decision was. I know they can do that. They have that right.
I'm just looking for ways to take down the empire.
Take down the empire, man. Remember Death Star, there's a little hole, and Luke Skywalker has to go. Yeah, it's very difficult. I don't think I'll give away there where that little chink in the arm. I haven't been able to find it. It's very difficult. It's a hammer, it's difficult. It's an offensive tool. It's not a defensive tool.
Nice. Well, this has been really good, Fawwaz. Thank you for enlightening us with this knowledge. I'm gonna pause the recording. We can do some chit-chatting here. Let's see.